Dear colleagues, dear friends, my name is Francesco Giammarile. I am a nuclear medicine physician working at the International Atomic Energy of Vienna, and my head of the section is Dr. Diana Paez, who spoke yesterday to you. Let me first thank all the organization, and in particular the Dr. Amelia, who kindly invite me for this very important event in Colombia. I will speak about SPECT in pediatric cancer, and my outline is the following. I will start with general context, with technical condition, particular in pediatric patients, the radiation protection issues. Then we will see pathologies, non-oncological, but of course mainly oncological, and then the conclusion. If you look at the competence that are needed for pediatric care, the first message that is the most important, and maybe the one that you should take home, is that children are different from adults. They are smaller, they are growing, they are higher life expectancy, and this is a very important aspect in oncology. And then they are also more sensitive to ionizing radiation. If you look at the diagnostic imaging in pediatric, we have to follow the following simple rules. First of all, the images are indispensable tool to determine the extent of disease and objectively the response of the treatment. This is clear. However, we are responsible for rationalizing the use in the context of each patient. Therefore, the choice of the modality must be agreed. A proper interpretation of the images requires experience and close communication between the clinician, the nuclear medicine physician, and the radiologist in case of hybrid imaging. Now, let's talk a little bit about justification. That is, what should I know before performing a procedure with ionizing radiation? First of all, is this procedure well indicated? Has this procedure been done previously? And this is very important because should we repeat or not? What is the most appropriate procedure? We have to look, for instance, in a procedure that doesn't employ ionizing radiation. Will you modify the diagnosis after this procedure? This is not easy to know before, but what is very important is, will you modify the treatment? This is a question that you have to ask to your clinician, because if the result is that it will keep the same treatment with or without the imaging, maybe you don't need. And finally, what is the risk? You have to evaluate the risk-benefit ratio. Moreover, if you look at hybrid imaging, we have to consider the radiation protection, the patient characteristic, the radiopharmacy with the activity and the biodistribution, but also the CT with the acquisition parameters and the field of view. The advantage is that you have an exact localization and anatomical orientation, very important for surgery and radiotherapy. You have less equivocal findings, therefore you increase in specificity. Moreover, you have the CT detection of the lesion with the low or no activity, and therefore increase the sensitivity. We have time saving for acquisition and analysis. We have interdisciplinary collaboration with the radiologists, and probably a reduction of doses. Regarding the specific acquisition parameters, first of all, of course, we have to explain to the child, if possible, to train on brief with command, also if possible, and to perform sedation or anesthesia, especially if the child is less than 3 years. The activity, it's according to body weight, following the E&M dosage card. In case you perform low-dose CT, the parameters are the following: 12 to 15 mass, 80 to 120 kVE, and a system of online dose modulation. If you do the diagnostic TC, first of all, you have to ask yourself if we have to do that. This could be if there are alternative methods like ultrasound or MR. If you have to consider all the body or a specific part of the body, and the parameters are, of course, higher, as you see. You can also use contrast media if you want. Of course, you need an automatic injector. This is also particularly important if you consider one-stop shop. So in your hospital, you do only one exam, one CT, that is embedded in the SPECT CT. The most common indication of SPECT or PET, if you look at this table, are essentially, in benign cases, is the bone lesion, somewhere neurologic in case of especially MR, but also eventually SPECT CT. What are more important in malignant cases are neuroblastoma, bone sarcoma, and soft tissue sarcoma. In this case, SPECT or PET CT are really very important. Now let's look at the diagnostic imaging in pediatric oncology. You see that regarding what we said before, we can use SPECT CT neuroblastoma, that is 6%, soft tissue sarcoma 7%, eventually brain tumors 25%, and stop. However, 60% of those tumors requires diagnosis and follow-up with imaging, of course. Looking at neuroblastoma, there are, of course, specific tracer, SPECT or PET. Regarding SPECT, we have the MIBG or also octreotide. And for PET, we have MIBG, F-DOPA, octreotide, and MHAD. This is an example of a comparison of a patient with FDG and MIBG of neuroblastoma. Of course, we don't see the same thing because MIBG is specific. FDG see only the aggressiveness of the tumor that is particularly expressed in this primary site. SPECT CT is very important in bone lesion, benign or malignant. In case of suspect lesion, the TC will help you in the analysis of the bone structure. This is a case of a benign kyst, with no rupture of the cortical bone, so the high signal in bone scan correspond exactly to the kyst. Another example is the spondylitis. Again, the TC can help to see the analysis of the bone structure. Here, clearly, this lesion corresponds to a benign lesion. In case of osteoid osteoma, also again, we have a typical, in this case, a typical site. Here, I don't think that TC can help too much. However, in some cases, and I have a personal experience of suspected lesion by MR that was a simple osteoid osteoma. And finally, if you look at endochondroma, this is a case of a patient that was referred to us because of oncologic history, and therefore he performed this SPECT-CT with the clear enchondroma, vertebral enchondroma. Of course, what we are looking is osteosarcoma with specific SPECT and PECT tracer. SPECT is the bone scan and PET is FDG, but also fluorine. If we look at this case with FDG, is a child of 16 years old, good responder. If we look at the bone scan performed in January compared to the May, we have a complete disappearance of the signal. The same patient, this is another patient with FDG and HMDP. You can see the osteosarcoma that is uptaking the FDG but not after treatment, while the osteosarcoma is seen before and after the treatment. Of course, the image before is related to bone tumor and the image after is related to bone scar. Now, what are the take-home messages? First of all, regarding the technical condition, of course, children are different from adults. Using a low-dose CT, we have to follow the guidelines, in particular in the administration of the correct radiopharmaceutical at the correct activity. We have to, in this case, the exposition to the radiation are different, a little bit higher than the single SPECT. If we consider the diagnostic CT, this only in cases where the indications are the similar in oncology essential. The pathologies. In benign, we have essentially SPECT-CT, bone SPECT-CT. For malignant, there are few indications, and all those indications are possibly replaced by PET-CT. Thank you very much for your attention.